Yeah, thank you, Sahu. Thanks for inviting me. And I think this discussion would be fruitful for all of us. We have four panelists, three from Indore and one from Bhopal. And this is a sponsored symposium. So straightforward coming to the case. He's a 54-year male smoker with no comorbidities, and he presented with a history of cough and dyspnea for 4 weeks. And the basic investigation was done is X-ray chest POV and which suggestive of right hilar lesion and which is a suspicious for malignancy. You can see the CT scan was done subsequently, which suggestive of hilar lesion. And then we come to the discussion. The patient is when underwent bronchoscopy by pulmonologist, which suggestive of morphologically small cell carcinoma of the lung. So I'll start with my discussion with our panelist. I think Dr. Rajesh, if you're there, I would ask you, like, what would be your preference of additional work of how you investigate in a patient you are suspecting for lung cancer?
Sir, this is a small cell patient with small cell lung cancer and CT is suggestive of locally advanced. So I would like to stage optimally with PET scan and MRI brain.
So in practice, you do PET scan and MRI brains in all patients, even if the patient has been.
Yes, sir. And so if I'm planning for chemo radiation.
Okay, so you will definitely stage with the PET scan and MRI.
Yes.
So anybody is a different talk, Dr. Deepak, Dr. Mehlam, and Dr. Vijay? Any other investigation you will do?
Yeah, I will go for CT scan chest abdomen.
CT scan chest abdomen. Okay. No MRI brain?
MRI brain, if it is localized, then I will go for MRI brain.
Okay. So if the patient is already metastatic, suppose this patient having the liver metastasis, you won't consider MRI?
No.
Okay. Dr. Mehlam?
I think even if it is metastatic, I would like to go with MRI brain.
Okay. Dr. Rajesh in favor of MRI. Dr. Mehlam and Dr. Vijay?
Sir, I would.
Please, Dr. Mehlam, continue.
Yeah, sorry. Sir, basically a PET CT if feasible. And even if it is metastatic, I would also like to go for an MRI brain initially.
Okay. Okay. Dr. Vijay?
Yes, sir. I am in favor of MRI brain, even advanced stage, to rule out, to look for brain mets, and that will help me to decide look for brain radiation or further follow up with MRI brain. Okay.
So majority of the panelists would be agree if doing MRI brain, even the patient is under a PET scan. Anybody was want to do a IAC because this morphologically small cell, but in your practice, do you consider IAC in every patient, or you could just rely on the pathologist suggesting small cell and you'll start your treatment?
In my practice, if a pathologist is reporting in the small cell lung cancer, I will definitely go for IAC.
You'll get to. So Dr. Rajesh in favor of IAC, and what about Dr. Deepak?
Yes, I will go for IAC.
So small cell you won't start without IAC. Okay, Dr. Mehlam and Dr. Vijay.
Yes, sir. IAC definitely.
Okay.
Sir, if patient is smoker,
yes,
then if patient is a smoker, then I may rely on the pathologist. If that is small cell, she is clear about the histology, then I didn't go for IAC.
Okay, so majority of in our practice, I think also we do the IAC most of the patient. Only if there is a very clear-cut radiological picture in favor of the clinical diagnosis and the pathologist is very clearly shaped. If there is any kind of the confusion or very poor definition, I think it is no harm of getting the IAC confirmation because your entire treatment is going to be modified based on the histopathology. So anybody would be doing any additional test because in small cells, there is some of the data suggests I'm doing a bone marrow aspirations and like alkaline phosphatase to rule out metastasis. Anybody up to that?
LDH.
LDH, yes, yes. So bone marrow, anybody would do bone marrow in their patients? No.
I do when there is something of a blood investigation that is pointing towards that. I would do. If a PET scan is also suggesting me that could be infiltration, I would like to document the bone marrow.
So I think I would agree with Dr. Sahu, especially if there is a if you are suspecting anything is myelophysis in your blood picture, so especially if the platelet count is low, you may maybe even this, particularly if the scan is not picking. I think that would be, I think, my approach.
Yes,
but if there is obvious metastasis and blood profile is okay, I think it's not going to do much change the treatment part. So what about the biomarkers? Anybody would be do any kind of the biomarkers before starting the treatment? Dr. Rajesh,
No, sir.
any biomarkers you do in small cell?
No, sir. I'm not doing any biomarker.
Dr. Deepak?
No, there is no biomarker actually for small cell.
No, no biomarker. No, you don't do any, even a PD-L1, Dr. Vijay?
No, sir. Right now, we are not doing any biomarker for a small cell.
Okay. So I think there is some data on the biomarkers, especially on the TNB and the PD-L1. But in small cell, there is a mixed data. The checkmate data where the PD-L1 doesn't correlate with the response, and TNB is one of the data where they're showing the response in checkmate study. But in Empower studies, actually even the TNB doesn't correlate. And Keynote study, the PD-L1 is a positive patient there, the response. So as of now, I think we agree with all the panelists. There is no clear-cut data, the biomarker-based treatment in small cell lung cancer. So we rely on the morphologically and the radiological reduction is started treatment. So this patient, as most of the panelists agree, this patient underwent the MRI brain and was just positive for multiple CNS metastasis, though the patient is totally asymptomatic for the brain lesions. And there is no history of any headache, seizure, or any other brain symptoms. So I think we'll start with, so the final diagnosis comes with a small cell carcinoma of the brain metastasis. And now what would be the next line? So Dr. Vijay, what will be your preference? Do you treat radiation, brain radiation first or then systemic treatment, or will you consider the systemic treatment first? Dr. Vijay.
I will consider systemic treatment first and look for patient to be symptomatic. Then I will treat.
So you will consider only systemic treatment, no brain radiation in asymptomatic patient. Dr. Deepak?
I will go for systemic treatment first.
Okay. Dr. Rajesh and Dr. Melam, you will agree, or you have a difference in opinion?
Yes, sir.
I will go with systemic therapy first, and after completion of chemotherapy, I would go for radiation.
So I'll
So-
agree with the same only. Systemic
Okay.
treatment first.
So systemic treatment first, but
Radiation is more.
radiation after completion of the
Yeah.
chemotherapy. So
One
Dr.
second.
Rajesh and other panelists would not consider radiation. Okay. So I think the data in asymptomatic.
I'm the only one, Ashish, who's erring towards RT and then chemo. I understand the data is for asymptomatic. Don't do that. Doesn't change. But you told multiple brain mets. In the reality, if one conversion happens to this patient, then I think it is a doomsday. So I
Yes.
totally agree. The data is there, but I do not know how comfortable I am. I'm little very uncomfortable.
So that is the clinical scenario. I think so your own experience maybe probably a little guide. But if you see the data, I think most of the patient would be, I think we in asymptomatic patient, the systemic treatment we can consider first. And I think as Rajesh was saying, they may consider radiation depending on the patient, any kind of symptoms or any deterioration. Not even in the seizure, we need to definitely consider immediate radiation. But in asymptomatic patient, most of the data in favor of avoiding the radiation upfront.
And if there are multiple, really does the panel outside the scientific forum does not advise radiotherapy? Multiple brain mets?
That's fine.
Is it that how you? I totally agree. The
Sir,
data
this is a very chemosensitive tumor, and in my practice, we are giving chemotherapy first, and if patient is not responding or patient has seizure or some symptoms, then at that time we are giving RT.
Can I ask one more question? Sorry, Ashish, panel. I would like to know, is there any data for the intracranial response to chemotherapy for small cell lung cancer alone?
I don't think.
Anyone aware of it?
Sir,
I think there is a limited data, but if you see the platinum can cross the blood-brain barrier, especially the cisplatin, and there's a data there may be response. I think that would be a clinical decision, but if you see the data, if the patient very small lesion, multiple, I think patient is symptomatic, I think our radiation oncologist would definitely delay the treatment. I think systemic treatment would be line of treatment as the data shown. And even you can see in the NCCN and even the extensive stage brain metastasis patient is asymptomatic, you may consider systemic treatment. Of course, it's a clinical decision. Nothing is wrong in treating the radiation.
No, Ashish, I totally back the data, and the data is not there at all for it. I totally back.
Yes. So considering the treatment options. So now this patient is asymptomatic brain lesions, and we have various data in the small cell lung cancer. The platinum with the is a gold standard in last 3 decades we are using in our practice. Now the discussion is about any other treatment which could benefit for this patient. So let me start with Dr. Rajesh. What would be your preference of treating this patient? You said the systemic line would be your preference.
So cost is no bar. I would go with immunotherapy and chemotherapy.
Yeah, cost is it's an academic discussion, so we can
then immunotherapy,
leave it aside.
chemotherapy. But
So yeah,
I have never used this.
Okay, you've not used. Anybody would be a difference? They will keep the immunotherapy for the subsequent line. They will consider initially chemotherapy alone. Dr. Deepak, Dr. Vijay.
No, sir,
No, I will
immunotherapy
go
is
for
not therapy which can be saved for further line. It should be given upfront. So the benefit, if it is there, it will be long remission. Patient should be get benefit more and more.
Okay, Dr. Melam, your comment?
So same actually with the first line only immune checkpoint inhibitors also along with platinum.
Okay, so I'll keep this fourth option other, as Dr. Sahu was saying, he will treat with the radiation then systemic treatment. So I think there is another way. So see the response. I think we all know with the systemic treatment, especially with the chemotherapy, with the various combination, I think we can reach up to 8 to 10 months of OS, which is the data. And I think as Dr. Vijay spoken, using the first line with the best combination immunotherapy with chemotherapy and not keeping the immunotherapy with subsequent line, I think because the small cell, most of the patient die within a year. So I think using the combination would be the preference. But now, what combination? So we have a 2 drug, atezolizumab versus durvalumab. We have a 2 data of Empower 133 and we have a Caspian data. So Dr. Rajesh, how will you proceed for this patient? Dr. Rajesh, you have to unmute yourself. You have to unmute. Okay. Dr. Vijay, you can take this.
Oh, sir. Basically, this is theoretical discussion for all of us. I have not any hands-on experience of using immunotherapy in small cell variant, but I think we'll go ahead with atezolizumab with carbohydrate.
So you will consider atezolizumab. Dr. Deepak?
In my opinion, both these options are valid. We can't do cross-trial comparison, but in both these studies, there was a 2-month survival difference, either with durvalumab or with atezolizumab.
Okay, and Dr. Mehla?
Sir, either 1 or 3, like atezolizumab with carboplatin etoposide or durvalumab with there's no cross comparisons. Okay. Actually.
And Dr. Rajesh, if you can unmute yourself. Okay. So, yeah, Dr. Rajesh.
Yes, sir. I agree with Dr. Deepak and Dr. Vijay.
So the data is there for both the agents, but there is still some of the fine difference. I think I will let you know. Like in Empower, where the atezolizumab is combined with chemotherapy, it's taken in all the corners, no biomarker selection, both the studies. But if you can see untreated brain metastasis, which is excluded in Empower, which is included in Caspian study, the PCI is allowed in the control arm with Empower and Caspian also, but in experimental it is allowed only in Empower studies. And the main advantage of the Caspian is in the control arm up to 6 cycle, where in Caspian it is 6 cycle, in Empower it is up to 4 cycle is allowed. And flexibility of both the platinum, cisplatin and carboplatin, both is allowed in Caspian. So that's, I think, a more real world kind of the clinical practice. So this is a very important, and especially if you see in this patient, there is a asymptomatic brain metastasis and you want to use a systemic treatment, I think the data favors the combination, but I think you can see that Caspian, where the untreated brain metastasis patients are allowed. And this is the summary of all studies, especially the Empower, Caspian, as well as we have a pamlozo data on the Keynote 604, and we have enablement data. So if you see the median OS, which is 12.3 months with Empower and durvalumab, which is around 13 to 12.9, the PFS is almost similar. Both the studies that the patient is very well tolerated. So comparatively, this is not a head-to-head comparison. We know this is a cross-trial comparison. But if you see with this study, I think there is a more real-world use of this agent, especially the durvalumab and the chemotherapy. I think that gives a more flexibility user, because I don't think so we stop the chemotherapy of just a 6 cycle. I think I would prefer if the patient taking chemotherapy, I will consider for 6 cycle. So any comment on that, Dr. Rajesh? from your side? Or how you will take this data?
Yes, sir, agreed.
Any now, because with this data, any of your preference? Because especially you can see the last slide, the more flexibility of the platinum, there is a use of 6 cycles. So do you see there is any difference in your practice?
Sir, I still think we can do both any of this, because we have phase 3 trial for about both. But as you said, there are 6 cycles we had given in KCPN trial. I might choose the KCPN trial.
Okay, Dr. Deepak, what will your preference?
Seeing this untreated brain mets patients are excluded from this atezolizumab study, I will prefer than durvalumab.
Yes. And Dr. Melam?
Sir, as sir said, actually, because the untreated patients are excluded, so definitely durvalumab would be a preferred choice at this point if we see the data.
Dr. Vijay?
Yes, sir. Now you mold all of us towards the durvalumab because
so Vijay, that's take home story. Give radiotherapy, both are eligible for both.
So I'm coming to that part. So that's why because that's why I've chosen a specific case, because there is no data at comparison, but this is actually my.
But still, there is some points in favor of durvalumab, especially brain met patient excluded from.
And this is the real world practice. I think I don't stop giving 4-cycle chemotherapy. We all consider 6-cycle. I think this is.
Can I ask a more provocative question to the trial? Yes. Is there any difference of 4 versus 6 in a non-responder? Anyone with a stable disease, if I give 6 versus 4, do I do more benefit by giving 6 cycles?
No.
Anyone can take it.
Yeah.
Because see, if the patient is not responding beyond 4 cycles, giving 6 cycles would not matter much. If there is a response between 2nd and 4th cycle, still the response is continuing, I will probably give 6. That's how I practice. If the 2nd and 4th, the stability of disease there, normally, do we benefit by giving 2 more? That's the moot question which we need to answer. If that is not, the 4 versus 6 question really would not be much of a difference to me. I think I need the panel's opinion. How do they practice 6 and versus 4? Even Akash is there, he can also jump in.
Sir, we give 4 cycles as standards.
In small cell lung cancer?
Small cell.
Small cell.
No, I think I give 6 cycle in small cell lung cancer. In other like non-small cell lung cancer, I give 4 cycle and then plan for maintenance. But in small cell lung cancer, I am giving 6 cycle of carbohydrate.
No, the question is data that 6 benefits more than 4.
So it depends upon the response. If the patient is responding, definitely continue up to 6.
Yeah.
But most of the patients, small cell, they are chemosensitive diseases, so they will respond early on.
Continuing to respond beyond 2 to 4 is the question.
So if they are responding, continue 6. If not beyond 4 is stable disease, then not continuing beyond 4, sir.
Okay.
So it's a more kind of the practical judgment, as you rightly mentioned. If the patient is not responding 4, less likely to respond 6. But the data says beyond 6, there is no real advantage.
Agree.
So 6, you can give 8 or 10, is not really advantage. But your patient is tolerating very well, responding clinically. I think I would love to finish the 6 cycle, and I think most of all of us are doing in our time.
And one more question: how many of us practice cisplatin today in small cell lung cancer?
I think I would be more majority of the patients cisplatin. I think
you give cisplatin, Ashish?
Yes, majority of the patients.
Carboplatin.
I
don't get cisplatin.
Okay.
Carboplatin. Most of the patient I know.
Okay. I have also myself changed from cis to carbo now because I feel it's more convenient, lesser nausea. The efficacy is equal. I think I have also shifted. So
anyway, patient
less fluid.
Yeah. Anyway, patient is admitting for 3 days. So managing cisplatin first, because most of the time this toxicity comes in the first 48 hours. So I think we'll manage that. So that's why I'm still strict to the cisplatin. Only thing if there is any issue of any underlying comorbidities, cardiac, where the patient.
Ashish, anything again? Can I ask you anything that compels you to go for cisplatin still, because we have a delayed toxicity as a side effect of cisplatin? Nausea does persist beyond 4-5 days also.
Yeah. So really speaking, till now I think I'm very comfortable. Like head and neck,
because of the comfort level and both are equal.
So I am not facing major issues, and like head and neck, we are using cisplatin. So I believe cisplatin is somehow still we are able to manage, and there is no major issue. So we are still in the gold standard treatment.
In good performance patient and in early stage especially, I may consider cisplatin. Otherwise, in extensive stage or all other patients.
So this discussion is for extensive. Early stage definitely cisplatin is the preferred.
Yeah.
Okay.
So there is also data of this Caspian study. I think this is important because this patient is having the brain metastasis. You can see in durvalumab with chemotherapy, the median OS is 12 months. You know, in intent to treat population, it is around 13 months, and the HR is also positive. So compared to the chemotherapy, it is 8.8 versus 12 months. So really significant. The HR is 0.69. While if you see an Empower 113 in the patient, those who have been received radiation, I think the benefit is not there. HR is 1.07. The median OS is actually lesser. It's less. So eculizumab is 8.5 versus 9.7. Though the number of the patients are 10%, but even with the brain metastasis patient, they didn't do well. So I think with brain metastasis patient, I think we have a very clear answer. We should use the combination of durvalumab with chemotherapy. Now, role of the PCI in extensive stage. Dr. Melan, do you consider PCI?
Yes,
suppose
sir.
the patient is no brain metastasis, and suppose the patient having the lung lesion in the liver mets, and do you consider?
Yes, sir. I do consider still PCI, prophylactic granular radiation.
For all patients?
Yes, sir. For most of patients, especially who are responding to the chemotherapy. Yeah. Not
Dr. Deepak? Dr. Deepak?
Yes, we do practice PCI in patients who have responded, at least a partial response.
So more than PCI. Okay, Dr. Vijay and Dr. Rajesh?
Agreed, sir.
Yes, sir. We all giving
It has
PCI.
given survival advantage. PCI who is in the patients who is responding with chemotherapy.
Ashish, can I bring in a point here? I think
sure.
PCI, there is only one data which from Japan, if I don't forget it.
That is against the OS benefit, sir. Yes, sir.
No. I wanted to make a different point. So the data looks into that if you are closely following these patients up, then you might not do the PCI. On an Indian patient who's very insincere follow-up, I'd be very comfortable doing PCI. But otherwise, if there's very good patient who would follow up, do a MR once in every 2 months for a brain, then I think you might get away. Ashish, what
yes,
is your
so I think there's a Dutch data. I think on my next slide will take you this answer.
Okay.
So there's a data of the OS benefit. I think, and also you also raise the right points. Monitoring with the MRI, that would be another way. But I think most of the patient, if there is a partial response or CR, I think PCI is still, I think, more preference. But now this is everything in the era where we are only using chemotherapy. Now with the immunotherapy, I think we don't have a standard answer, because in these studies, there is even if the patient who completed chemotherapy and there is a more than PR or CR, I think they're still continuing with the maintenance immunotherapy. So the exact answer we don't know, but in selected patient, I think we are still considering PCI. And what about radiation to the residual primary, Dr. Rajesh?
Sir, I am not practicing this, and I am not aware about the data about locally BRT to the residual primary.
Okay. Dr. Vijay, Dr. Deepak?
Yes, sir. Some of patients which are responding in extensive stage and there is a good response and there is no distance match, then we may consider them for local radiation.
So we have a data for both these things. I think, as I mentioned, it is a Dutch study for the PCI, but you can see in the last paragraph, the immunotherapy patients, I think we have a very much selective, but there is no standard data. But in consolidated radiation, I think still, I think we do consider in this patient, I think especially those patients. So there is a Dutch studies also. So we do radiation if the patient having more than PR, especially if patient there is a residual thoracic primary, and all the other metastatic side is well controlled. So provided this patient is in good performance also. So this is the conclusion for the discussion. We are discussing since half an hour.
Can you go back one slide, please?
Yeah, sure.
Yeah, I think the last line really makes it, and I think all of us do the PCI. But if a patient who's, let's say we have a very high profile patient who's like a high end official or something, a big businessman, big shot, I think we should be aware of this Japanese data because it's a randomized trial. And it does tell us one story that if there is no brain mets to start off with, and the patient can be followed up and the patient is ready to do a routine MRI,
Yes.
I
yes.
think this option should be discussed because there would be long-term effects of radiotherapy to the brain. So
But
in the
it is-
legal scenario, I'll be very, I just wanted to highlight that. That's all.
Yeah, absolutely. I think, but that is really clinically challenging doing MRI. So most of the
Yeah,
time we consider this. Yeah.
We should discuss that.
Yes, absolutely. So to conclude this discussion, the durvalumab with chemotherapy is just one of the new standard. Although we have a data available also, but this first-line durvalumab with chemotherapy is improved OS compared to the control arm. And this is the real-world data. Most of the patients they receive the 6 cycle of the treatment. They also allow the use of PCI in the control arm. And this benefit is across all the subgroup, including the brain metastasis, which is very in around 1/3 patient we see in brain metastasis in our practice. Around 22% patient they have survived even beyond the 2 years. Now we have a 3-year data. It's around 17% with the durvalumab chemotherapy, and the response rate actually with the Empower it is similar to the chemotherapy to high. And durvalumab with chemotherapy it's a superior. It's 3 times more than the chemotherapy arm. And another advantage with this combination, after completion of the chemotherapy, the maintenance treatment is actually once in a month, which gives the flexibility, and the safety profile is there with these agents. With this, I thanks to all my panelists for their participation, and I hand over to Dr. Sahu for the final comment.
Thank you. Just last question to you, Ashish.
Yeah.
If you have a very good response, the extensive stage small cell lung cancer, there's a very small residual left behind on a PET scan, which is lighting up for the lung only. Would you go for a radiotherapy consolidation to the local site?
Yes, I would prefer. I would give at least 30 grade 10 fraction for residual primary. I do practice.
Yeah, so I think I am also trying to shift toward this type of practice because I feel there is some data, maybe a little bit of PFS rather than OS. I totally agree. I thought that I had to highlight.
Yes.
So anyone wants to make any point?
But I will also change my practice. I will start thinking about
Rajesh, your voice is
local
breaking.
to the
Can you come once
residual
again?
disease. I will also start giving referring the patient for radiation if it is everywhere disease control in primary is low.
Okay.
Sir, I also have a point, sir.
Yeah, please, Akash.
Sir, Ashish sir वाला background बहुत अच्छा है.
Ashish, please share the slide set with Akash so that he can copy paste it and use it. Ashish, take it as a compliment.
So
Deepak,
it's a virtual background.
Yeah, Deepak, you wanted to.
No, I don't have any comment.
अरे भैया तू आकाश आशीष से कंपेयर मत कर. हम छोटे लोग एमपी के अहमदाबाद लोगों से कंपेयर करेंगे तो ऐसे ही. और दीपक बड़ा सिटी छोड़ के छोटा शहर में आ गया. चलो. With that small things, I just wanted to end up with 2-3 things here. Do all the IOs are not made same? That's what Ashish has pointed out. The trial inclusion criteria is something that we should be taking into consideration if you are a very purist way of looking at trials. What Ashish really pointed out was if there is a brain mets, asymptomatic or symptomatic, if not treated, the data is more towards using Durva. If there is a asymptomatic or a stable brain mets on a patient who has received radiotherapy, probably you have both the options. That's point number one, what I take off it. The platinum is something which I will not consider much, but the data which he put forward is there's more of a flexibility of cisplatinum and carplatinum towards Durva, while it was more of a carbo towards the Atizo data. Apart from that, the 4 and 6, all of us agreed that the responding patient, we will go for 6. If not, 4 is okay. And there are some panel, even I also do not go beyond 4 if there's not much of a response, but at least 4. So these are the things which need to be highlighted. Last point which I want to make, although it's a sponsored session, is the benefit of a 2 months good enough to the cost is something we need to discuss. But I think at the end of the day, we have to be professionals, give the best advice to the patient, let the patient decide for himself, is the money worth it? That's where we should be stopping, and that's our job to offer the patient the best possible treatments.